Okay, so next up we have Dr. Danielle Baribeau, who is a child and adolescent psychiatrist, and she's also one of the leads for the POND Knowledge Translation and Participant Advisory Committee.
Thank you. Hi, everyone. So as Alana mentioned, I'm a clinician, so I come at it with a clinical hat. I trained as a psychiatrist first, so it's a 5-year program working with adults across mental health conditions, and then I did additional training in child psychiatry and then additional training in development specifically. So the data I'm presenting is a little bit from a psychiatric lens about information gaps and a little bit on system gaps I'm seeing in the work supporting youth primarily with neurodevelopmental disorders and conditions. I'm also an epidemiologist. My research training is in epi. So how can you take a lot of different data and make meaning of it from either research studies but also from existing sources of data. So trying to be efficient in where we generate information from. I've grown up with PONDs. I've been trained by Evdokia for I think about 15 years now, ever since you came to Toronto, and I think I spoke at this day maybe 5 years ago, so thank you for being involved in my training and participating in this study and helping me continue this work. So mental health. So mental health is a top priority. With the priority engagement setting, anxiety came out, treatments came out, behaviors came out as important for youth with neurodevelopmental conditions. This is data on autism. I do have a practice focused very much in autism, but if you looked in ADHD or OCD, mental health conditions don't tend to run alone. Very rarely does someone have one thing only and they fit a single group, so they tend to go together. This is data from across all of Sweden, and this is using administrative health data. So what that means is if you're a Swedish person running around in the Swedish healthcare system and you have an interaction with a doctor, some little file gets made about you and they analyze that data. And so what this is showing, the take-home point from this, is that mental health concerns like depression and anxiety and sleep problems are higher for autistic youth and adults, and more so for females than males. And we know that in mental health broadly, conditions like depression, anxiety are more common in females than males as you get into adulthood. The other piece I want to take home from this is the rates of service use that people with neurodevelopmental conditions need and require into adulthood. So from the Swedish data, by the age of 25, 60%, so if you're looking at the top graph there, cumulative incidence, 60% of autistic women had received a co-occurring psychiatric disorder diagnosis of some sort. And if you look at the bottom graph, that has to do with inpatient, so psychiatric hospitalization for mental health concern. So my hope is that you or your children don't have to experience a psychiatric hospitalization. I've worked in this system for many years, and there are big gaps with how we manage and support young people. But what this is showing, at least in Sweden, is that this is a common occurrence for individuals with neurodevelopmental differences. Data are not that different when it comes to Ontario. So this is a paper that came out just recently, and this was looking at emergency room visits for self-harm events in autistic individuals in Ontario across the lifespan. Reading this graph, it's a cumulative incidence. So what this is showing is that top bar are autistic female participants. You're seeing this rise between age 15 and 30. You're having emerge visits for a self-harm event, and then it kind of stabilizes after that. And the average would be for autistic females would be one to two per life kind of thing. So the chance of having a self-harm event is high. And again, hoping that you or your children don't have to experience that, but it is something that is occurring in the system, and we need to better support. The other thing that stood out for this with me, and I'm a psychiatrist, right? So I see kids who have been everywhere and then finally get to me, is kind of what I would consider serious mental illness, so schizophrenia, bipolar disorder. Some of these conditions where you really need longitudinal, supportive, specialized care in early adulthood is the focus here as well, over age 18, not just pediatric, to get accurate, to get appropriate care for these disorders. So one of the challenges we're facing is that data are very limited when it comes to treatment of mental health conditions in the setting of a neurodevelopmental condition. And this speaks to what the clinicians, the doctors you're seeing know or would have been trained in or can easily look up. I have a patient who has a neurodevelopmental disorder and is now presenting with what I think might be depression or psychosis, and what do I do? The short answer is that very, very little guidance about what one should do. So we have anxiety is probably something that's been studied the best. It's very clear if your child or you can participate in cognitive behavioral therapy, it on average is helpful. We don't have clinical trials for anxiety medications. We're running one shortly, but we don't have data on that. There's very little, almost nothing, published on depression, some kind of pilot therapy groups, but nothing on what medications are best. And I'm talking about in autism specifically, but you could generalize this to other neurodevelopmental disorders. Data are very sparse. And don't even get me started on psychosis, bipolar, personality, trauma. Trying to get someone trauma therapy in the setting of a developmental condition is next to impossible for many reasons, for funding and barriers and expertise, but importantly, data. We don't have good data to show what one should be doing or what works. So I added this here. It's a very important, getting the data is very important because it will help advocate for system change. And so something I'm coming up against more and more in my work is exclusion criteria for mental health programs into adulthood often include developmental disorders. We don't do autism, we don't do intellectual disability here. And often, if I send enough angry emails, people still get in and it works, but there isn't a streamlined experience. And I'm sure as parents or caregivers or individuals with neurodevelopmental disorders, you've experienced this in some way if you're in the early adulthood range. So gaps and opportunities. We have limited data on mental health outcomes and service needs. And so the other thing is advocating for service needs by showing service needs is a way to hopefully change service availability. When we're using administrative data, like the Swedish graphs I showed you, those types of administrative data have lots of holes. Those diagnoses are based on a busy clinician like checking off a button and not, gold standard diagnostic assessment. And it also requires that you see a doctor. So if you were diagnosed by a psychologist or in the school and it's not part of the health data, you're missed in that data. But opportunities, we have large and rich research data sets, thanks largely to families like yourselves who have contributed and to researchers like Abdikia who have led initiatives. And so we have good data available. And we now have the capability, which I'll show you, to link those two together. So research good data sets with health outcomes over time. And an interest of mine is, what do we do with these genetic disorder diagnoses that are made? Does this have any meaning when it comes to anticipating mental health concerns as kids are growing up, anticipating care needs as kids are growing up, and what do we do with treatment when young people are coming with serious mental health concerns and I have to pick what to do with treatment? Does the genetic diagnosis change anything going forward? And we've heard a few examples where yes, maybe in a few conditions we have some data emerging, but this is an emerging interest of mine. In the name of time, I will summarize this for things like Phelan-McDermott syndrome or 22q deletion syndrome or some of the more common rare conditions. You can get a big enough group of individuals together to start to make meaning out of treatment experiences and treatment pathways. But for many rare conditions, and maybe for some individuals and families in this room, you may be one of a handful or one of a few. And so looking at ways we can cluster, as Dr. Scherer mentioned this morning, cluster data into something that may be more meaningful as a pathway or a network. I'll say, so I see a lot of kids with genetic conditions in my clinic, and I always look up the guidelines and say, what am I supposed to do? But teach me about this condition. And they all say associated with mental health or behavioral or developmental differences. And then the recommendation is seek psychiatric care. And then it stops. And then I say, I am psychiatric care, what do I do? And there's nothing more. And so My hope is maybe in 10 years I'll come back with some data for you to change that needle a little bit. So what we've done, so we took pond data, and this has been envisioned in pond from the get-go. How can we, in a identity-preserving, confidentiality-preserving way, make the best use of this data? And so we've taken the kids with pond who have undergone the deep phenotyping that you've all done. That's very extensive. And we've had that data linked to kids who've had genome sequencing at sick kids. And then through probably 3 years of form filling and legal discussion and administrative oversight and privacy decision makings, we've been able to link this to health data for the province. So this would be, and I put a little lock here to say, no one's looking at you individually. It is impossible. It is so protected, these data. They're on a server that I can't even access. Only the health analyst people can access it. And they only let you look in groups, and they don't collect your name. But the idea is that the one-time commitment of, a few days of deep research stuff, we can use that to study someone over the lifespan, which is amazing in terms of adult outcomes and service needs. So the first research questions from the pilot were, can we link the data? Can we do it securely? Will they let us do this? Short answer, yes. I'll tell you in a minute. And two, as a proof of principle, as a first question, we asked, does a genetic diagnosis affect your health service utilization? So pond kids who have had a genetic diagnosis compared to pond kids who don't have a genetic diagnosis, does this affect what health services you need or use? And this focused in childhood. Here are some examples of the type of data that is collected. So this is all in big databases that is not designed for research. So if you imagine 1 million numbers and codes and you need to get some specific analyst person to pull the values for you, but things like when you're discharged from hospital, somebody somewhere has to check a box about why you were there, how much blood work you had done, what medications were prescribed. If you see a doctor on an outpatient basis and they bill the government for that visit, they have to put a diagnostic code about why you were there. So these are the data I'm talking about. One thing that hasn't really been explored much for the province, but that I'm keen about, are medications. So for controlled substances like ADHD medicines, that's tracked. So we could actually look to see who's taking what and how long did they continue it over years. So we successfully linked. So for the 419 kids who were part of the pilot project, the data were linked for 99%. This happens through the health card. So if you were signing up for POND and you didn't give your health card, which many people just didn't, then you wouldn't have been linked. And it goes through a very fancy encryption process where it gets sent over encrypted and then de-encrypted and then that way. This is comparing kids with genetic sequencing done at sick kids by Dr. Scher's group who had an autism-associated variant or not as of 2019. So this is how long this has taken to get going. Again, so very confidential. Let's see. This is the main outcome slide. So how does health system use and for what indication vary between kids with and without rare genetic variants? In purple, we have no variant. In blue, we have variant. Side note, everybody has different variants, so we all have a bunch of different ones. We're all born with some, and we all acquire some as from during embryogenesis. I'm talking about ones that we've known to be associated with neurodevelopmental symptoms or traits here. And so what you'll see, as you'd expect, if you look kind of in the middle cluster, kids with genetic conditions are more likely to see a surgeon or a neurologist, ENT or nose and throat, so maybe like craniofacial stuff. But what was surprising to us is that kids with the variant were less likely to seek or receive mental health care in the system. So this is it for the data right now. This is the only outcome, so we're exploring about what that could mean. But if you look at the purple bar in terms of outpatient mental health, having seen a psychiatrist, having been to emerge for psychiatry, kids with variants are less likely to use the system. This is focused in a 3-year window during childhood. So coming to conclusions, this was a proof of concept study. Can we do it? And the answer was yes. What's important about it is it's leveraging existing data. This is not dragging everybody back into another visit and doing detailed interviews about how many times did you go to emerge. These data exist, so it's an efficient way to answer really important questions. Limitations about this, we're only looking at childhood, we're only looking at publicly funded health service use, and we don't have an explanation for this finding yet. It may be that, and I have some ideas and we're going to test them out, it may be that kids with medical complexity in the setting of a genetic diagnosis face barriers to accessing mental health care. It may be that they are diagnosed in a different way, that the kids without variants are more likely to come through psychiatry to their developmental disorder or developmental diagnosis, whereas kids with variants maybe are more likely to come through pediatrics. It may be differences in need. It may be that the mental health concerns that sometimes we see in adolescents don't start till adolescence for some kids based on their biology. So next steps, we are updating the genetic data, so new pipelines, big fancy stuff that I don't understand here at Sick Kids in terms of coming to these summary genetic classifiers. We're going to look over adolescents as the POND participants are aging. Now many are early adulthood age. We're going to increase the sample size to everybody who's possible to link now. And I'm going to delve deep on mental health outcomes. So what is happening, who's being diagnosed with what, who's needing what services, and hopefully look as well at medication patterns. And then are there ways that we can cluster looking at pathways or groups or subtypes of genetic conditions to see that maybe they face unique barriers or resiliency or needs as they're entering early adulthood. One particular concern of mine is if we can show that kids are at increased risk of serious mental health concerns into adolescence, then we are compelled to develop services and programs for that. So it can help support that goal. So take-home points, there are system barriers. We need data to change the system, and we can get that data using your contributions already linked to health administrative data sets overall. Thank you. Are we going to do 2 questions, Elena, or move on? Because I think we're behind.
Hi.
Oh, hi.
So looking at why these kids don't come in with the variants, as a parent, I immediately think prioritization, parental overload.
Yeah.
You know, you've got a lot to deal with, and maybe these things don't quite meet your threshold for the most urgent.
If you've got 6 specialist visits, do you really need to also go see a psychiatrist right now? Yeah, absolutely.
And and is there anything that can be done to support the parents in helping their kids, or to make that more accessible, integrate into their other visits, that kind of thing?
Yeah, and I think hearing the program from Dr. Williams and this idea that maybe you don't need to come to a psychiatrist to get the support earlier on. There are conditions where that you do need that specialty level of care, but for much of early childhood anxiety, support the families early on, and maybe it's not going to get to that point. So embedded in programs is great. I really like that suggestion. I see a flashing light here. Yeah.
Hi, Danielle. Great talk. I just wanted to maybe make a comment or hear your thoughts on what the role of intellectual disability is here, and how hard how much struggle it is to diagnose psychiatric conditions in those with intellectual disability.
Totally. It both affects system access, complicates system access, and complicates diagnostic certainty. So the ICES data. As a side note, ICES used to be ISIS, and then when anyway, there's an interesting story around the name of that. But with the ICES data from Meng Xuan's study, 15% with a diagnostic label of psychosis seems high for me, and I think that speaks to frontline clinicians seeing someone with big behavior change and saying, like, I don't know what to call. I don't know what to call this. So there is uncertainty in diagnostic assessment. That said, over time, I think when you add a time component to things become more clear for many kids. So, and you can do that. There are reliability codes about if you have 3 or more visits for XYZ, it is more reliable than 1 visit for XYZ. So absolutely.
Okay, I was just waiting to see if I stopped flashing.
Oh yeah, hi.
Hi, I'm interested in the intersectionality between mental health conditions and communication disorders.
Yeah.
So I'm not sure, is there data, or do you know if there's data through ICES on people who cannot speak?
No, and that is
So clearly that's a barrier.
Yeah, absolutely. We would have that through POND, right? So we would have detailed language. So it speaks to the limitations of administrative analyses using only health administrative data. You don't have cognitive variables. You don't have language variables. You can start to pull income from neighborhood geography, what neighborhood you're in, but so you lose that context. Okay. I will say in this data set in the 419, the genetic versus non-genetic groups were slightly different for mean IQ, but not dramatically so, I think by about 6 points, 6 or 8 points. And we didn't look in detail at communication, but we can and will on the next iteration. Because it makes a big difference, right? If someone can explain what they're experiencing versus not and how they can.
Yeah, and whether or not the communication partners can communicate with them. You know what I mean?
Yeah.
So my daughter can communicate pretty well, but there's no clinician that could have a session with her.
Yes,
because they don't know how to make it work.
Yeah. I can think of very good.
Anyway, I'm interested to hear about all that.
Yeah, great. Okay, I'm gonna run. Thank you, everybody.